not so complicated, and it's day 6 clinical case discussion series 6, and the case looks like this. A 50-year-old male presents to the outpatient clinic with a 5-day history of cola-colored urine and bilateral leg swelling. He reports a sore throat 2 weeks ago, treated with over-the-counter lozenges. Past medical history includes hypertension 5 years and amlodipine 5 mg daily, and he denies diabetes, smoking, alcohol, or any recent NSAID use. The vitals are BP is 150/90, which is slightly raised, and HR 82 normal, RR 16 normal, SpO2 is 97% is normal, and temperature is 36.9 degrees Celsius. And extremities have 2+ spitting edema to mid-sins. So what do you know until now? Cola-colored urine, bilateral leg swelling, and there is 2+ spitting edema in extremities, which means it is a real case of kidney disorder. Let's look into the labs. Serum creatinine is 2.0 mg per deciliter, which is increased, and BUN 35 mg per deciliter, K plus 4.8 milliequivalent per liter, and Na plus 139 milliequivalent per liter. SO3 minus is 21 milliequivalent per liter, and albumin is 3.8 gram per deciliter. Okay, and urine shows 3+ hematuria, 1+ proteinuria, red cell casts, and fractional excretion of sodium is 1%. And CBC, hemoglobin 11.8 gram per deciliter, WBC is 7,000 per microliter, and platelets 200,000 per microliter. Other tests show that ASO titer, which is anti-streptolysin O titer, is elevated, and C3 low, C4 is normal, C3 means complement 3 and C4 complement 4, and ANA, which is autonuclear antibody, is negative. So what is the most likely diagnosis, and what is the next step in management? Let's see our options. The options are acute tubular necrosis and post-streptococcal glomerulonephritis, IgA nephropathy, minimal sense disease, lupus nephritis. We will debunk each of these options, and what is special is about this case discussion, like always, is that we not only answer which is the right answer, we also debunk each of the other options and explain why that is wrong answer. Let's go to the option A. The option A is acute tubular necrosis, and let's debunk it. Acute tubular necrosis usually results from ischemic or toxic cause or injury to renal tubules, leading to acute kidney injury. And ischemic is due to prolonged hypotension, but our patient has hypertension. And toxic, that is aminoglycosides or NSAID use or radiocontrast use, there is no history of recent NSAID use or injury to. And also there is elevated creatinine and oliguria and tubular dysfunction in acute tubular necrosis. Elevated creatinine fits, but not only that, there are other symptoms to be considered, and urinalysis typically shows muddy brown casts due to slowed tubular cells, not red cell casts. There are red cell casts in this case, but usually the acute tubular necrosis shows muddy brown casts. And in the figure right here, we can see that the ischemic or toxic insult causes atrophy in the tubular cells, and thus the disease gets the cells get injured and sloughed off, and the sloughed off cells accumulate and form a cast that usually obstruct the renal tubules. That is what happens in acute tubular necrosis, but that is not the case in here. There are red cell casts, not muddy brown casts, and also fractional excretion of sodium is usually greater than 2% in acute tubular necrosis, but it is not the case in this situation. And also there is no recent hypotension, surgery, nephrotoxins are significant, and side exposure, as I said earlier. And the presence of red cell casts indicates glomerular, not tubular pathology. And also the history of sore throat, elevated ASO, and low C3 are unrelated to ATN, which does not involve complement activation, and this is very unlikely. And also in the histopathology, we can see that there are necrotic areas in the slide there are necrotic areas which is due to acute tubular necrosis in there. The arrows show that also along with the normal cells in there. The second option we got is post-streptococcal glomerulonephritis. Let's debunk that. It is usually an immunocomplex mediated glomerulonephritis. Typically occurs 1 to 3 weeks after a group A streptococcal infection such as pharyngitis. So our patient has sore throat 2 weeks ago, which means it might be the case of group A streptococcal infection, and that is complicated, may cause immune complex mediated glomerulonephritis in this case. And also there is high ASO titer, there is low C3 and normal C4 in here. So let's see what else is here. Gross hematuria, which is cola colored urine, mild proteinuria, edema, which is the edema, that pitting edema in leg swelling, that our patient has, totally relates into this. And also red cell cast in the urine, low serum C3 with normal C4 indicates complement activation by the alternative pathway, which is a typical feature of PSGN. And the absence of systemic symptoms, that is rashes, arthritis, or AN negative, further supports PSGN over other glomerulopathies. So this is highly likely case of post-streptococcal glomerulonephritis. And also in the morphology, you can see in our right side that light microscopy shows enlarged hypercellular glomeruli, and that hypercellular means there will be 3 criteria. This is the infiltration of inflammatory cells and proliferation of endothelial and mesangial cells, and also crescent formation, which is in severe cases, and it results in the obliteration of the capillary lumen. And in tubules, it may contain some red cell cast, and in interstitial edema and inflammation may be there. And the image below is of immunofluorescence, and in post-streptococcal glomerulonephritis, the immunofluorescence generally shows granular deposits of IgG. But in anti-GVM glomerulopathy, there is a linear deposition of IgG, that is in contrast to that. And also the third option we have is IgA nephropathy. IgA nephropathy is also called Burzer's disease, and it is most common glomerulonephritis worldwide, often presenting with gross hematuria 1 to 2 days after an upper respiratory tract infection, unlike PSGN's 1 to 3 week lag. So there is difference between IgA nephropathy and PSGN in a sense that the onset of nephropathy after upper respiratory tract infection is varies in duration, that is 1 to 2 days in IgA nephropathy and 1 to 3 weeks in PSGN. So that is a dominating difference between these two glomerulonephritis, and it causes nephritic syndrome with hematuria, mild proteinuria, and occasionally edema or hypertension, and the red cell casts may be seen mimicking PSGN, but C3 and C4 levels are normal in IgA nephropathy, which is not the case in our presentation. So this, and also ASO titers are not elevated in this case, and in this option are IgA nephropathy. In IgA nephropathy, ASO titers are not elevated, and IgA nephropathy often recurs with infections. Diagnosis typically requires renal biopsy showing IgA deposits, so it is very less likely, but it may confuse you with PSGN. But the dominating feature or the difference that we can do in here is the duration of the onset of nephropathy. We also can see that HIT 1 and HIT 2. HIT 1 elevated circulatory GD IgA1, and HIT 2 is the production of IgG autoantibodies, and in HIT 3 the formation of IgG GD IgA1. GD means galactose dependent, and IgA1 containing circulating immune complexes. That immune complex which is formed then circulates in the capillaries of glomerulus and causes the glomerular injury and mesangial deposition, obviously, and those deposits are granular in nature, and in immunofluorescence there are granular deposits that is seen as we saw earlier in the photo. And also the option D is minimal change disease. Minimal change disease is a nephrotic syndrome characterized by heavy proteinuria that is greater than 3.5 gram per day, hypoalbuminemia less than 3 gram per deciliter, and edema and hyperlipidemia, often triggered by infections or NSAIDs in children or young adults. So Also, we have the case recap in above, and we can contrast the findings in minimal sense disease with the case recap that we have. So it is a very unlikely case of minimal sense disease, and also often and urine analysis shows only 1 plus proteinuria, and normal albumin is 3.8 gram per deciliter, ruling out nephrotic syndrome. This is not a case of nephrotic syndrome, we can say that. And not podocyte injury typical of MCD, and MCD is diagnosed via biopsy, normal glomeruli on light microscopy, effaced through foot processes on electron microscopy. We can see the foot process effacement, which causes the foot process effacement, which is the major effect of minimal sense disease. And the hypoalbuminemia, albuminemia, and edema, hyperlipidemia, how that occur, we will talk in our next videos, upcoming videos. The pathogenesis of these all symptoms we will talk later. And the fifth option that we have is lupus nephritis, and let's debunk that. Lupus nephritis is a complication of systemic lupus erythematosus, and it presents with nephritic or nephrotic syndrome, hematuria, proteinuria, rare cell cash, and renal dysfunction. It is driven by immune complex deposition causing low C3 and C4 levels, but in our case C4 levels are normal and is associated with positive ANA, but in our case it is negative ANA, and anti-dsDNA antibodies are also negative. And this patient has a negative ANA and normal C4 and no systemic SLE features, so it is not a case of lupus nephritis, we can say that. And lupus nephritis requires biopsy for classification. So diagnostic criteria in systemic lupus erythematosus is SOAP brain MD. This is very high yield, and we can remember with SOAP brain MD. SOAP, S for serositis, and O is oral ulcers, A is arthritis, P is photosensitivity, B is blood disorders, renal involvement, ANA positive, immunologic where anti-SM and anti-dsDNA, and also N for neurological symptoms, and M is malar rash, and D is discoid rash. Malar rash is also called butterfly rash because it presents like a butterfly. And WHO classification of lupus nephritis is class ILN, where there is no histological senses with light microscopy. Class 2 LN, mesangial-proliferative glomerulonephritis. Class 3 focal proliferative glomerulonephritis. Class 4 is diffuse proliferative glomerulonephritis, and class 5 membranous glomerulonephritis, and class 6 is scar glomeruli, which leads to end stage renal disease. And the diagnosis is obviously PSGN, post-streptococcal glomerulonephritis, and the pathogenesis here is the streptococcal pyogenic exotoxin B, SPEB, in the most of the cases can be planted in subendothelial locations, which leads to the formation of in situ formation of immune complexes, and they dissociate and migrate across the GVM glomerular basement membrane, which is of note also made from type 4 collagen, and type 4 collagen is also present in lungs. And if there is any autoantibodies formed in type 4 formed against type 4 collagen, it leads to Waterhouse-Friderichsen syndrome. We will talk about that in later cases. And those reform on the subepithelial side of the GBM in this case. And also in situ formation of immune complexes result in inflammation, causing infiltration of inflammatory mediators. Another way is that it can form immune complex within the circulation, and those circulating immune complexes get trapped within the glomeruli, causing inflammation. And the another way is that it can directly activate complement systems. Also, the clinical features of PSGN, as we talked earlier, there are a lot of clinical features. There can be strep pharyngitis 1 to 2 weeks earlier, and strep skin infection or impetigo 3 to 6 weeks, which causes glomerulonephritis, and the symptoms include hematuria, hypertension, periorbital edema. That is it. And also alpha hemolytic bacteria that cause PSGN are Streptococcus pneumonia or Streptococcus viridans, and also Staphylococcus viridans, and also beta hemolytic group A pyogenes and group B agalactae. And 6 weeks after pharyngitis or impetigo, a patient develops PSGN. The tea-colored, cola-colored, or smoky urine all signifies the same and is a case of PSTN. And the symptoms also include edema, hypertension, hematuria, proteinuria, as we talked about it earlier. And the labs are blood urea nitrogen or creatinine, and urine analysis, RBC proteins, ASO is high, complement level is low, like type 3 hypersensitivity, and also we have to do biopsy. We have to treat the symptoms, protein restriction, treat edema, hypertension, prognostic is good in 90%. So let's go into the management of PSTN. In the management of PSTN, we have to do the supportive care earlier, fluid and sodium restriction. We have to limit dietary sodium less than 2 gram per day, and fluid intake match urine output plus insensible losses 500 to 800 ml per day to manage edema and hypertension due to hypervolemia. And we have to monitor daily weight and urine output to guide adjustments. And also diuretics. So we have to administer loop diuretics such as furosemide 20 to 40 mg IV or oral titrated to the effect to reduce edema and control blood pressure if fluid overload persists. But we have to also monitor for hypokalemia. K plus 4.8 milliequivalent per liter is borderline, recheck post-diuretic. And antihypertensives continue amlodipine 5 to 10 mg per day for BP control. Because if we stop the amlodipine, it also increases the blood pressure, causing eventually causing hypertensive nephropathy. And also the target is to maintain less than 130 by 80 mmHg to protect kidneys. We have to add an S inhibitor, which is lisinopril 5 to 10 mg per day if proteinuria increases, but monitor K plus already 4.8 milliequivalent per liter and creatinine closely, as PSTN can worsen hyperkalemia. And also treat underlying conditions. We have to treat underlying infections, although the sore throat result confirm streptococcal clearance. If there is an evidence of active infection or positive throat culture, we have to prescribe penicillin G 1.2 million units, IM single dose, or amoxicillin 500 mg TID for 10 days to eradicate residual streptococci and prevent recurrence. For penicillin allergic patients, use erythromycin 250 mg QID for 10 days, and we have to monitor renal functions, check serum creatinine, BUN, and electrolytes every 2 to 3 days initially to assess acute kidney injury progression. PSTN typically resolves spontaneously in adults within weeks, but persistent creatinine elevation greater than 2.0 mg per deciliter beyond 4 weeks warrants nephrology referral. And also we have to manage complications. If there is hypokalemia 4.8 milliequivalent per liter is mild, restrict dietary potassium. Example, avoid bananas or oranges. If K plus exceeds 5.5 milliequivalent per liter, we have to use potassium binders. Example, sodium polystyrene sulfonate 14 to 30 gram oral, and then recheck. We have to also manage metabolic acidosis. SCO3 minus 21 milliequivalent per liter is borderline, no immediate bicarbonate needed unless bicarbonate falls below 15 equivalent per liter, then consider sodium bicarbonate 650 mg TID oral. We have to manage oliguria, urine output not specified if less than 400 ml per day, assess for severe AKI, Doppler ultrasound to rule out obstruction, or thrombosis if oliguria worsens. And glomerulonephritis, there is the symptoms in a visual format: headache, increased BP, facial or periorbital edema, lethargic, low-grade fever, weight gain, which is due to edema, and proteinuria, hematuria, oliguria, dysuria, which means painful urination. And there is anuria term too. Anuria means less than 100 ml per day of urine output. And also the prognosis of this disease is most adults recover fully within 6 to 8 weeks with creatinine normalizing, and less than 5% progress to chronic kidney disease, but monitor long-term 3 to 6 months for proteinuria or hypertension. There is a spectrum of glomerulonephritis attached in here. You can pause the video and look at the details, because this is very high yield for USMLE PLAB. You can get the summarized version in here. So subscribe for our next video, our next case discussion. And thank you for watching this video, and share too, and comment down if you have any special requests. Thank you.